Time now for this week's Health Matters. Paul Critz with you, along with physician assistant Lynn Szabo. We have guests in the studio today. We're joined this week's Health Matters, Kathleen Denault, addiction counselor here in Del Norte, and then my lovely wife, Lisa Critz, who is an opioid addict in recovery on Suboxone, because that's what we're talking about today. Suboxone and its use, its history, but mostly some changes coming to the local Suboxone scene. Is that correct?
Big changes. So mostly it kind of stems from the fact that now all licensed healthcare providers in California can prescribe it. It used to be you had to have a special X license.
Okay.
And that means special training. And then they got rid of that. And so I think it's going to change how some of the community clinics prescribe Suboxone. And some are going to be the same. Some, like Del Norte Community Health Center, for example, has a pretty successful program. Mm-hmm. But that's going to change a little bit because Dustin Jaco, one of the one-name wonders over there, is going to take over the Suboxone program, and I think they have 80 people. They're kind of capped at 80 people.
Wow, okay.
And a super good program. But other clinics in the community or other providers are just going to prescribe it, which I personally have some issues with. But let me go ahead and define Suboxone. So it's actually two drugs. That's buprenorphine and naltrexone. And it's a partial opiate agonist, which means it kind of clogs up the receptor sites, so that opioids, you don't really get the high from it anymore. They don't really work very well anymore. Used to be, I think the original formulation of it was Subutex, and that was just buprenorphine. From my research, that's not made anymore. But that was super addictive and kind of a big problem.
Wow.
You could, I think you could overdose on it. So they kind of reformulated it and also kept it from being injectable, crushing it up and injectable.
Mm-hmm.
So, but this is a kind of an interesting topic for me in particular because so many people seem to need this. Kind of in the aftermath of the Sackler. I'm going to call it the Sackler area, the Sackler model, where pretty much they marketed opioids to healthcare providers. This feels a little bit, this change in Suboxone right now feels a little bit to me like the beginning of the opioid epidemic and how providers were kind of roped in.
Okay, so how so? What are the connections? What are the things that you fear will happen? And how is this situation not changed by the fact that we're talking about Suboxone now?
So I think Suboxone still has the potential to be abused. And it's actually kind of what I see it used as a currency to go out and buy a drug of choice. Okay. And Lisa's just
now beforehand you said you weren't going to speak unless spoken to about things, but you're like making all kinds of gesticulations over here.
I'm so sorry, I'm nodding with agreement.
Yeah, no, go right ahead.
Okay.
It's often diverted.
Really?
Often diverted, yeah. And unless you have a program where there's a consequence for that, like you're out of the program, or that you have toxins and providers are able to pick it up, to me it seems like we're just in the opioid epidemic again with kind of a different drug.
Wow, okay.
With a lot of pressure on providers to prescribe, and a lot of people who are not prescribers going, this is so great. Now there's going to be access for everybody. But access without accountability is a big problem for me.
And that is the correlative right there. That's the connection. It's the access. It's the kind of the pushing of this drug without any sort of accountability. It's the same sort of scenarios with the beginning of the opioid crisis.
Right.
Okay.
So, Lisa, do you feel like you can talk about, you're in the Del Norte Community Health Center
I am,
program?
yes.
Okay.
And
how does that work there?
There are consequences, correct?
Yes. The thing that happens if you come up positive for any other drug is that they'll take it and they'll give it to you every day. You get your prescription, you bring it to the clinic, they test you every day, they give you your medicine, you take it in front of someone because then they know you're not diverting it for heroin. And we've had people who were found to have done that, and they're not thrown out of the program. They get a few chances.
Yeah.
But if you're found to not be taking your medicine, then you have to come in every day. You have to be given it. You have to take it with a witness. And I think that's important.
So has that been your experience too, Kathleen?
Yeah, that's exactly what my experience is that, like Lynn and also Lisa said, is that, people will go in with no accountability. And if you don't have that accountability, the first thing that a person who has in any kind of addiction is going to do is that they're going to go seek their drug of choice. That's the very first thing they're going to do. So keeping them accountable and having them also not only the thing that concerns me with doctors being able to prescribe the Suboxone without accountability is that there's no counseling there, because you need to have that counseling part of this whole entire caveat. Because if you're just handing out the Suboxone, that person's going to take that Suboxone and they're going to go on and trade it for their street drugs. And one of the new things that they can do with the Suboxone is that they set it on fire, they melt it down, and then they inject it. And so it gives it a complete different high, because it takes away that naloxone.
Are people just not aware of Suboxone having this sort of value, this kind of worth? I mean,
I don't think that
I guess by people, I mean our healthcare providers.
And that's what I was going to say. I don't think that I think either they don't know or they're turning a blind eye to it. I'm not real sure, so I can't answer for that.
I can answer that. The people who've been doing medically assisted therapy for opioid dependence are over it, and they're done, and they got threatened a lot, and it doesn't work from their point of view. They want somebody to be better, and it takes a long time, and it's frustrating, and so they want everybody else to kind of share what they see as a burden. And it really feels so much like the beginning of the opioid thing. You must do this if you're a good provider. And I get told a lot, because I have resistance to it, that it's really safe, it's easy medicine, but they're looking solely at the medicine and not at the patient.
Right.
And I just saw somebody yesterday who wanted, just for his dependence, he just wanted a pill. If he just had a pill, he was going to be fine. But if you think about something like the 12 steps, like the fearless moral inventory and making amends, that's really soul shredding work.
Yeah.
And people just kind of want to drop that part, and they want it to be easy. And I think they really do a disservice to themselves and also the people around them, who are probably getting burned out on their addiction.
So when you say that providers are over it, what do you mean? What's that attitude that you're describing? They're over what?
Being yelled at, being threatened.
Over the more like human interactive component of treatment like that? Are you saying that there's a desire? It's more
the addict that wants what they want when they want it.
Okay.
And they see the provider as the means to get it, and they don't see all the the kind of rules we have to go by. There's like legalities of it. There's standard operating procedures in your clinic. There's interfacing with the pharmacy. It's super complicated. We can't really just hand it out like candy.
Right.
But we're the front person that gets. When I was prescribing opioids on 10th Street in Humboldt. It was a long time ago now, about 15 years ago, people would stop in the streets. They'd stop their car in the middle of the lane and yell at me because I didn't go along with what their hopes were.
So are you saying that there might be like an inclination for providers to just kind of fall into some sort of like, I'll just prescribe you the drug? Is that what you're saying? Or is it?
I think we're being told to do that, actually, and we're not really being told to do that by like an educated medical advice. We're being told to do that by people who, if you just gave me the drug, it would be great.
Gotcha.
And without any further thought. So I find this direction like really the wrong way to go.
Wow.
I like Open Doors plan, but I think individual provider just handing stuff out, there's no accountability there.
So do we have any concept? We've talked about Open Doors plan and how Open Door here locally is different and maybe in some ways sort of immune to some of these concerns just because of the the difference it has. Can we speak to that difference? How is the open door program? How is it? Will it or will it not be able to deal with this sort of pressure with Suboxone? Because it seems to be like it's very group based. It's very much about the therapy and not just about that. I mean, and there are consequences, and you've told me about times
Yes,
when there are consequences. For
and
people.
Tony's amazing. And she
Right,
really cares.
right. That human side seems to be here in Del Norte
Right.
to that.
How do they work that, though, Lisa?
Well, depending on how long you have been in the program and depending on how long it's been since you may have had, a dirty test, you come to so many groups a week or so many groups a month, and you do your UAs like daily, weekly, monthly, depending on how much time you have. And, really, if you relapse, what you are told to do is come to more groups. Come to more groups, talk to Tony, do individual counseling. It's more counseling for, any kind of relapse because they know. And most people are pretty honest about it. And we haven't really had a problem with people trying to fake anything or, I think that the vast majority of people in the program really take it seriously, and we all love Tony and we want to make her happy.
Is there a different sort of level of accountability because of the fact that it's such a small community, and maybe a lot of the people in the room know each other outside the room as well?
Yeah, for me, it's because I've been in recovery most of the time I've been up here. And for a lot of people who grew up here together, they all did drugs together, and now they're in recovery together.
Right.
And, when someone doesn't come to a group, we notice, where's this person? What's happening with this person? And we worry, and Tony worries. And I wouldn't want that to go away. I would feel lost without the group.
So
Is that what you see, Kathleen?
Well, with
You're nodding here.
open door, I see that. But with other programs that are in this area, if let's say the addict comes in, they have had a slip or they have relapsed. Well, they show us a dirty UA. Well, automatically, and if they're in the penal system, they automatically are thrown out of that program. They have to wait 30 days to come back to that program, or they get to go to jail. Wow. So in my view as being, and I am in recovery, I just want to let you all know that too. So in my view is that, you're punishing the addict for doing the behavior that they're so used to doing.
Right.
So that's what needs to be changed. And that I find Open Door is the only one around here besides there is another program here in this area that's through one of the tribes that does change, that does do that. They don't do the punishment. So the thing that needs to be looked at is when someone does go out and relapse or does come in and do a dirty test, then you need to address that. You need to look at, well, why did you relapse? What happened? Let's walk through it from the very beginning. Let's look at what you could have changed and give them the tools that they need so that doesn't happen again. Right. Because they already feel bad enough when they do relapse. They have that incomprehensible demoralization. They feel like they failed one more time in their life, when actually they haven't. It's just the behavior that they're so used to, and that's the thing that needs to be addressed. And I don't see that being addressed in a lot of programs. And if we're going to do the Suboxone, that's one of the things that I said earlier, is that we need to address the behavior that goes behind the use. If that's not being addressed, then it's going to be abused. And that's just the nature of the beast in addiction.
Wow. Okay. So, I mean, we talked about, and you'd mentioned, Lynn, there needing to be consequences for it's like we're talking about these consequences that follow along behind the use of the Suboxone, the prescription of the Suboxone. But those consequences, it's not just about having consequences like you're going to get kicked out. I mean, you have to have specific kinds of consequences.
Right,
that you're
specific consequences, but I also think that you have to give people tools to live their life better. And that's why I'm a big advocate for the 12-step and 12-step programs. Right. I think 12 steps are just rules for living right. And so if you give somebody a consequence for behavior that's not, desired or not in their best interest, then tell them how they fix that in themselves, tell them how they live their life. My favorite question to walk in a room with somebody in recovery is, what step are you on? If they have no idea what I'm talking about, they're lost.
Right.
If they say, well, I don't really do the steps because I'm just going to walk on the beach and try and be a better human, they're lost. They're completely lost. The best person I ever saw in recovery, I think he was in recovery 34 years, the last time I asked him that question. And he said, I'm on the first step. You always ask that. I'm an addict. I'm always going to be an addict. I'm on the first step. And he knew exactly where he was, and he knew how to stay there. And that his recovery to me was like such a remarkable thing.
That opens up a bunch of questions like I have for all three of you about how do you move beyond recovery then if you're always at the first step. Do you ever, is there a game, is that even a goal?
Well, okay, so I'm going to answer that question.
Okay, all right, cool.
So, and I'm sure that you will agree with me on this one, is that if you move beyond recovery, you become complacent. Okay. And when you become complacent, that's when all that thinking comes back in your head, the old behaviors come back. So it's kind of like, I like to describe it as either being the only way that I really can describe addiction is by a diabetic who has to take their insulin on a daily basis. So if that person doesn't take their insulin, what is going to happen to them? They're going to go into a diabetic shock. Their body's going to shut down. Well, basically, that's the same thing with an addict. You need to go to 12-step meetings. You need to have that connection. You need to be working on yourself every single day. And part of that is being through a spiritual program and finding some kind of spiritual being to help you through your addiction, because we have been our own power, so we need to find a power outside of ourselves. Sure. And I agree with what Lynn said. When I was first in recovery, one of the things that I had is this, to this day I remember him. His name is Monk. He no longer is with us. I would walk into the Alano Club down in Eureka, and he would ask me how much time I had, and I would look at him and I'd count on my fingers how many days I had and everything, and then he'd ask me that question again, and he'd go, how much time do you have, Kathy? And I go, well, I just told you how much time I have. And I was like, what am I missing here? And this was when I was first and new in recovery. And he would say, no, you just have today. And that's the reality of addiction.
Right. So what role does Suboxone play then in that scenario?
So Suboxone helps with the addict to relieve the withdrawal symptoms. And I mean, it's great for that part of it. But again, one more time, is if you don't have the 12 steps and the behavioral health part of it, then it's not going to work because you're still having that same thinking. So it's basically what the Suboxone is doing is helping the addict to relieve from the addiction. Now, I know a lot of addicts who have gone through this program and no longer have to use Suboxone at all. They don't use anything at all. They taper them off of it.
Because it is a matter of having to kick the Suboxone as well, right? I mean, it just sort of takes the place of that.
But it shuts up those mu receptors that make you like threaten your healthcare provider at 10 minutes to 5 because you were hoping to get an early refill so you could
Sure.
do
And so
whatever it is you wanted to
so
do.
without any sort of what we talked about earlier, that kind of that structure of consequence or of therapy or of moving forward in some regard, then you just end up with somebody who's on a maintenance level of Suboxone without any sort of interaction with the system or any sort of plan for moving forward or beyond that, right?
There's no structure at all.
Yeah. And so you just end up with somebody addicted to something else.
Well, also on the other hand, too, is like, how Lynn said that, that because we have this opioid epidemic, I mean, we have put these people that are on opiates for chronic pain for so long, is that now we have to find some way of getting them off of that. And, you just can't like take it away from them. You can't
that was
do
such
that.
A big
So
part
we
of the
have to
problem.
find a different way of, looking at maybe we can use Suboxone as a pain relief, or to have them find out some different ways that we can, change their way of thinking for using those drugs too, because opiates are, even though they're can be a good thing, they can also on the other hand be a really bad thing because in the withdrawal symptoms from opioids, and I'm sure that you can attest to this, is that the opioid withdrawal symptoms is that, you have sweats, you have headaches, you have vomit, your body has chills, and your muscles ache, and all you want to do is sleep all the time. And, it's this is not just a few days of this. It's that, it takes a total of 30 days for the opiates to get completely out of your system.
It's not the Keith Richards 3 days, 72 hours, and you're free. Yeah, no, it's not like that.
Yeah.
So you were waving your arms. What's up?
And I just want to make sure that another thing that Suboxone does is it keeps people from dying.
Mm-hmm.
There was a beautiful young Native woman who died this month from Crescent City who came to the library, and we talked about recovery, and she died from an accidental fentanyl overdose.
Mm-hmm.
And then the brother of my best friend down in Palm Springs, he died from a heroin overdose. And, I want Suboxone to be funded and available. I want there to be a lot of programs for it, because maybe those people wouldn't have died if they had the Suboxone. And ideally I want there to be therapy with it, but I think something some people don't understand, it's not just another drug, Suboxone. It's allowed me to live stably and keep a job and have good relationships and be all right with my family, and I don't lie or steal or do things that are untoward anymore. It's some people in AA will say, oh, you're not sober because you're on Suboxone, but I'm okay with that. I'd rather take it.
It seems like it's kind of like analogous to it, because we've also just quit smoking recently, and so we're in this whole thing where we're chewing the gum, which feels like a Suboxone kind of scenario, right? Where we're chewing the gum to keep the pressure off, but we're not doing the habit anymore. We're not inhaling that. We've changed the shape of our lives around it. So what's needed then? If this is if you can't just, because I can sort of see like the opioid, the Sackler scenario, it being so huge that, why not address something in an analogous sort of situation and just throw Suboxone at it? But you have to do that with some sort of plan, because, or we've talked about this a lot, and you've tried to cut down and have cut down on your Suboxone just personally, just because of the nature of it being a continuing addiction. Yeah. What comes next? What sort of, I can see the problem being so big. Let's put Suboxone in. Let's get these people in some sort of maintenance thing and take the pressure off. And then there's a pause. Then what should happen after that? What should be there for folks?
We should staff behavioral health. For some reason it's scant up here, and people burn out quickly. And I think it's because they're overwhelmed.
Is that just an up here thing? Or is that like everywhere nowadays?
I think that's a rural America thing, actually. Okay. But I think that might be part of the reason that providers are being called on to do this kind of partial job. It's just because the other piece is missing. And I'm not in on the meetings where they recruit people and stuff, but I wish they would recruit more, because where the boots are on the ground, we really, really, really need these people. And if you think about it from an administrative cold, hard cash point of view, because this comes up a lot in our talks on Health Matters, if you get, let's say, 15 people together in a group therapy with a provider in another room and a counselor running the group therapy, then the person leaves the room, meets with the provider for like 3 minutes, and then goes back to the group. That seems to me like that would up the numbers. So a provider could probably see 15 people in an hour, which mostly they see 3. So that would be huge, because the provider wouldn't be the one that's responsible for the patient's soul. Right. Because we never really succeed on that. I think how many times we're like, wow, cholesterol, hypertension, lose weight. And people immediately get offended by that. It's not the issue they want to talk about. They're more worried that their wrist hurts maybe. And it just seems like it's not the tool to do the job. Right. And if you wanted to do it in a group therapy kind of format, I think it could be financially feasible to staff it more.
I'm interested in how the open door scenario differs from adjacent communities or elsewhere in California, as far as the Suboxone and the group therapy and
my sister goes to a methadone / Suboxone clinic in Medford, and they have, I think, 3 counselors for 800 people. They have groups that are 40, 50 people, and they're all still by phone. There are no in-person groups. My sister personally hasn't seen a counselor in over a year. She goes every 2 weeks for her methadone. Nobody seems to care. They are a publicly traded company that with the stock.
Okay, so it's not a government sort of
no,
thing.
it's they get government money though, but they're beholden to their stockholders, and so that is a worse scenario or bad scenario, maybe not worst, but
do you know, is it a for-profit company
yes.
as opposed to a nonprofit?
Yes,
okay.
it's a Acacia Healthcare, I think it's called.
Okay.
See, that seems to me like some kind of weird storage place for addicts.
Yes,
Right.
That's exactly what it is.
it's what it feels like. I've been in there with her.
That's horrible.
It is. If you're going to have...
Everybody closer to their microphones.
All right.
We've all relaxed into this now. We're kind of sad.
If you're going to have some kind of recovery model where you're having, you're going to have a provider and you're going to have the behavioral health person and you're going to have, the different levels in behavioral health. You have the psychiatrist because we all know that addicts have co-occurring existing.
They have no psychiatrist.
Yes. So
Right, yeah.
So we need to have the psychiatrist, and then we have the psychologist who does the therapy afterwards, and then we have the addiction counselor, and then who runs the groups or does the one-on-one for addiction, and then we have the physician or Lynn as a PA. So we have all of those things, and if that's how a successful recovery center really works, whether it be intensive outpatient or it be residential. That's how it works. And there is nothing in this area up here that fits that description.
Is there anything anywhere that is publicly funded that fits that description?
Waterfront does. If I was going to have choices to send anyone anywhere for locally around here, it would be Waterfront, because Waterfront does have all of those things. And again, too, is that you can have the addict or the person who has the substance use disorder person, because that could be alcohol too, go down to Waterfront, and once they get there, you drop them off at the door, they can turn around and walk right back out again.
Right.
So that's the other thing with addiction. The person can be court ordered. They could be family ordered. They could be, highly suggested by a physician that they need to go and do these things. But if they don't have the desire to do it, it's not going to work. They're just going to do it and go through the motions. Maybe they'll get some kind of, little seed planted in there. So the next time this comes around, that maybe that seed will grow. But the addict needs to have the desire to stop.
They've got to cultivate that seed themselves.
They've got to have that.
Yeah. It just seems like with all of the things that are necessary, all the sorts of support structures that you need to really treat addicts as humans, that this kind of just throwing Suboxone at the problem seems like the best we could do with the current system. This is just kind of the best we could hope for. Is that not? I mean, just the way things are built now. Okay, what do we have to deal with? What's the tool in the toolbox with our system that we've constructed right now? Well, okay, here's a pill. Here's a pill that might help some people. Here's a pill that'll keep people quiet.
Right.
Here's a pill that'll hopefully tamp down some things. It's not going to cure anybody, but it might make everybody more manageable.
It's a Band-Aid.
Yeah.
Yeah.
That's all it is a Band-Aid.
But I could see a physician thinking, going back to Hippocratic Oath, do no harm. And that, from a physician point of view, I'm not a physician, but that feels like doing harm.
What feels like doing harm? I'm sorry.
Just handing a pill to somebody who needs much, much more.
Yeah. Yeah.
So-
Yeah.
And that's what we did. That's what we did say with pain. Here's a pill.
Right.
And then,
Exactly.
in some systems, people got strung out on pills, and that's all the care they had. They didn't have any diagnostic insight. They didn't have any referrals to specialists. That's all. This feels exactly.
No, I can see that. I can
the
see
same.
that. After all of this conversation, this half hour, I can totally see the parallels now between. So then we just have a couple of minutes left. The takeaways. What needs to happen? What do we need to do?
Well, I think what's going to happen is that you're going to have a bunch of reluctant healthcare providers who are going to be prescribing it, and it will either be a success, which I doubt, or it won't be, and then respond and modify, I suppose.
Do you think with if it's not a success, which it probably wouldn't be, that would in somehow affect existing Suboxone programs and maybe water down their public
if it's demonstrated that it can be done on paper for less money, I think the administrative world would jump. Insurance companies certainly would jump all over that.
Yeah.
But it's somebody in recovery. Successful recovery is a really beautiful thing. And I'd like to see more of it. So I'd like to have the resources so that people can do that.
Okay. Well, we're coming up on just a half an hour. I wanted to do this. I wanted to ask both Kathleen and Lisa as well your last thoughts. Lisa?
I just have one thing, and I feel like, there needs to be a lot more than just giving Suboxone to people. But at least if we do that, it'll keep them alive to keep fighting for better recovery programs in this country, because people just keep dying. People I love, people I know, and all kinds of people I don't, and it's heartbreaking.
Right.
I'm just tired of people dying from opiates.
Yeah, that's interesting. And we talked about the Hippocratic Oath and doing no harm, but that's the tricky part of that is that right here in the moment, doing no harm might be like, oh, let's save your life. Down the road, unless something else happens, then that's not a good thing ananymore. We've saved your life for a minute. Yeah. Kathleen?
So what I see happen is that more times than anything is that if an addict goes back out and they use again, they're shamed. We got to take that stigma away from the addict. And it's not a choice. It's something that happened, from trauma or whatever it is in their life, that they chose to use this drug or whatever their substance is to relieve whatever that was. And now they are an addict, and we need to help them. They're just like a cancer patient or a diabetic. They're a sick human being that needs help. And when we get to that point, I think that's when recovery and all of these programs will be successful.
Right.
Thanks, Kathleen.
Yeah, thank you
That was
both.
a profound ending point.
Yeah, and thanks and this is a conversation. I mean, I would love to revisit. There's so much going on here and so many different things to examine over and above just Suboxone, just addiction and recovery in general. So, Kathleen Denault and Lisa Critz, thank you so very much, and Lynn, thank you for this week's Health Matters. That was very good. Any thoughts about next week?
The idea lady from Del Norte Community Health Center, Maria Durazo, is coming to talk about her thesis project, which is using telehealth to treat diabetics.
Wow. All right. That'll be next week on That Health Matters. And that's all for this week. Thank you very much.